Today we will discuss the approach of hypocalcemia, low calcemia. First I will highlight few conditions of hypocalcemia. One is vitamin D deficiency. Vitamin D deficiency can cause hypocalcemia, and vitamin D dependent rickets type 1 and type 2, and renal insufficiency. Renal insufficiency can cause hypocalcemia. Any other causes? Pseudo-hypoparathyroidism, then hypoparathyroidism, and calcium sensor receptor defect. All this can cause hypocalcemia. Okay. Regarding phosphate levels, what happens to phosphate levels in vitamin D deficiency? Phosphate levels are in vitamin D deficiency. 125 dihydroxy vitamin D action is increased absorption of calcium and phosphorus from the gut. If there is deficiency, there will be hypocalcemia and hypophosphatemia. Phosphorus levels will be low in vitamin D deficiency. Vitamin D dependent rickets, VDDR1. Again, there is a conversion defect from 25 hydroxy D to 125 dihydroxy D. Calcitriol levels will be low in VDDR1. Okay. And calcitriol levels will be high in VDDR2, because in VDDR2 is resistant to calcitriol. Okay. In both these conditions, phosphorus levels are low. So in vitamin D deficiency and in rickets, there will be decreased absorption of calcium and phosphorus from the gut. So calcium levels are low and phosphorus levels are low. In renal insufficiency, in chronic kidney disease, there is phosphate retention, the decreased excretion of phosphate. So there will be phosphate retention. So phosphate levels are high. What is the action of parathormone, parathyroid hormone? Parathyroid hormone action is one, in bone, there will be resorption of bone, increased osteoclastic activity. So there will be release of calcium and phosphorus from bone. And second action is in the kidney, there will be conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D conversion. That calcitriol causes again increased absorption of calcium and phosphorus from the gut. And parathormone in the kidney, it increases absorption of calcium and it increases excretion of phosphate. There will be more phosphate excretion from the kidney if parathormone levels are high. So if parathyroid hormones are low, there will be phosphate retention. Parathormone causes increased phosphate excretion from the kidney. So if parathyroid hormones are low, there will be phosphate retention. There will be hypocalcemia and phosphate retention. So in the hypoparathyroidism, phosphate levels are increased. And even in pseudo-hypoparathyroidism, phosphate levels are increased. Pseudo-hypoparathyroidism means again PTH receptor resistance. PTH receptor resistance. So PTH levels will be high, but there is resistance in the receptor. The difference between these two is in hypoparathyroidism, PTH is low. In pseudo-hypoparathyroidism, PTH is high, but there is resistance in the PTH receptor. Okay, phosphate levels are high in these two conditions. Again, in calcium sensory receptor mutation, phosphate levels will be high. The CSR there is action in the parathyroid hormone and even in the kidneys. Okay. If there is defect, if there is mutation in the calcium sensory receptor, there will be decreased phosphate excretion that can cause phosphate retention. So what about PTH levels in these conditions? Parathyroid hormone levels in these conditions. If there is vitamin D deficiency, PTH level will be high. Vitamin D deficiency, there is deficiency of 125 dihydroxy vitamin D, decreased absorption from the gut, decreased absorption of calcium and phosphorus from the gut. So there will be hypocalcemia. That hypocalcemia causes secondary hyperparathyroidism. So PTH will be high in vitamin D deficiency. PTH will be high in even in the rickets also. In both types of rickets, PTH will be high. In chronic kidney disease, PTH will be high. Chronic kidney disease, PTH will be high. And again, there will be PTH resistance also. Even in pseudo-hypoparathyroidism, PTH will be high. Only in hypoparathyroidism and in calcium sensory receptor defect, PTH will be low. Coming to 25 hydroxy D levels, that is cholecalciferol. 25 hydroxy D levels will be low in vitamin D deficiency. Okay. In all other conditions, those levels will be normal, because in VDDR1, the defect is in the conversion from 25-hydroxy-D to 125-dihydroxy-D. So, if 25 OHD is low, that indicates directly only one condition, vitamin D deficiency. Other conditions, it is normal. So, coming to calcitriol, what will be the calcitriol change in all these conditions? Hypocalcemia, here vitamin D deficiency. So, only in VDDR2, calcitriol levels are high in VDDR2, because there is resistance to calcitriol. So, calcitriol levels will be high in VDDR2. In vitamin D deficiency, calcitriol will be low. Even in VDDR1, there is a defect in the conversion to calcitriol. So, calcitriol will be low. In other conditions also, in renal insufficiency, again 125-dihydroxy vitamin D synthesis is reduced. So, calcitriol will be low. In hypoparathyroidism, again calcitriol will be low. In calcium sensory receptor defect also, calcitriol will be low. So, in all other conditions, calcitriol will be low. Coming to urine calcium. So, in hypocalcemia, urine calcium will be low. In most of the conditions, urine calcium will be low, except in calcium sensory receptor defect, calcium sensory CSR defect. Because in this defect, if there is mutation, the abnormality is increased calcium excretion. The cause for one mechanism for hypocalcemia is increased calcium excretion. So, urine calcium will be high. So, in all the conditions, in hypocalcemia, in all the conditions, urine calcium will be low, except in CSR mutation. This is the flow chart. So, if patient comes with hypocalcemia, we will check phosphorus level first, then parathormone level, then we will check 25-hydroxy-D and calcitriol and urine calcium depending on the condition. Suppose if an infant presents with hypocalcemia and irritability, infant has diarrhea, hypocalcemia and irritability, and all these levels are normal. Phosphorus level is normal, PTH is normal, 25 OHD is normal, and calcitriol is normal. All the four are normal. Then what could be the cause? Patient has diarrhea. Diarrhea can cause magnesium deficiency. So that hypomagnesemia can cause hypocalcemia. We should look for those causes. We should look for those causes of hypocalcemia. First, we should rule out those causes before going to this flow chart. For estimating phosphorus levels and PTH levels, we should rule out magnesium deficiency, and boy with nephrotic syndrome presents with hypocalcemia, symptomatic hypocalcemia. Again, phosphate levels are normal, PTH normal, calcitriol 25 OHD normal. What could be the cause? Hypoalbuminemia. Low protein can give a hypocalcemia picture. Ionized calcium will be low. So, if there is sudden phosphate load into the body, again there will be hypocalcemia. So, we should rule out those causes, magnesium deficiency, phosphate load, low protein causes. Then only we should look for first phosphorus levels. Suppose if you check phosphorus levels, if phosphorus levels are low, there is hypocalcemia, and we checked phosphorus levels. Phosphorus levels are low. What does it indicate? What are the possibilities? Low calcium, low phosphorus. So the mechanism should be in the gut. Probably there is decreased absorption of calcium and phosphorus from the gut. So but then we should check 25-hydroxy-D. If 25-hydroxy-D is low, that indicates vitamin D deficiency. So if 25-hydroxy-D is normal, then we should check calcitriol. If calcitriol is low, that indicates VDDR1. Low VDDR1, vitamin D dependent indicates 1. What is the mechanism of VDDR1? The decreased conversion from 25 OHD to 125 dihydroxy vitamin D. So calcitriol levels will be low in VDDR1. Calcitriol will be high in VDDR2. That is because of resistance to the calcitriol. So in a patient with hypocalcemia, first rule out miscellaneous causes like magnesium deficiency, hypoalbuminemia, and phosphate load. Those causes we have to exclude. Then check phosphorus. If phosphorus is normal or low, means there is defect in the gut absorption, probably the main cause. Then we will check 25-hydroxy-D, cholecalciferol. If that is low, that indicates vitamin D deficiency. Okay. If cholecalciferol is normal, then check calcitriol levels. If calcitriol is low, means VDDR1, rickets 1. Okay. If calcitriol is high, means VDDR2. Why there is high calcitriol in VDDR2 because mechanism is resistance to calcitriol. So if there is resistance, calcitriol levels will be high. Suppose if phosphorus is high, so hypocalcemia with high phosphorus. So here phosphorus is high, next one is PTH. If PTH is high, what is the possibility? Hypocalcemia, phosphorus is high and PTH is high. In hypoparathyroidism, what happens? In hypoparathyroidism, there will be hypocalcemia and there will be phosphate retention. Okay? In hypoparathyroidism, there will be hypocalcemia and phosphate retention. But in hypoparathyroidism, PTH will be low. But PTH will be high in pseudo-hypoparathyroidism. Okay? Because pseudo-hypoparathyroidism, again, mechanism is resistance to PTH. There is resistance to PTH hormone. So PTH hormone levels will be high. But one important point is when patient presents with hypocalcemia, if phosphorus is high, we should not check directly parathyroid hormone. Before that, we should rule out chronic kidney disease. So check creatinine first. Before checking PTH, parathyroid hormone, check creatinine. If creatinine is high, that indicates CKD. CKD is the cause for hypocalcemia, high phosphorus levels. Okay. Even PTH will be high in CKD. Okay. So first rule out chronic kidney disease. Then check parathyroid hormone PTH. So if PTH is low, the classical case of hypoparathyroidism. If PTH is high and creatinine is normal, that indicates pseudo-hypoparathyroidism. There are 5 types of pseudo-hypoparathyroidism. Type 1A, type 1B, pseudo-hypoparathyroidism. Type 2. There are 5 types of pseudo-hypoparathyroidism. Coming to the various causes of hypocalcemia. Hypocalcemia can be due to decreased parathyroid hormone levels. Decreased parathyroid hormones can be due to parathyroid gland agenesis. That agenesis can be isolated or it is a part of DiGeorge syndrome. Okay? Parathyroid gland agenesis is the one cause. Then gland destruction. Gland destruction can be due to surgery or radiation to the parathyroid gland or infiltration. Infiltration of parathyroid gland. In hemochromatosis and various diseases, there will be parathyroid gland infiltration and autoimmune diseases. So, decreased parathyroid hormone can be due to parathyroid gland involvement, either agenesis of parathyroid gland, that is either isolated or with DiGeorge syndrome, or with the destruction of parathyroid gland either by surgical or radiation or infiltrative disease or autoimmune process, or there can be a parathyroid hormone resistance. What happens in parathyroid hormone resistance? PTH levels will be high in parathyroid resistance, or if there are G protein mutations or CASR mutations, PTH will be high and patient presents with hypocalcemia. And most important is vitamin D, low vitamin D levels and low calcitriol levels. Where PTH will be high, vitamin D deficiency or calcitriol deficiency. Various causes are one nutritional vitamin D deficiency or renal cause. In renal there will be decreased formation of calcitriol or vitamin D resistance. So hypocalcemia with high parathormone levels. So either can be PTH resistance or with G protein mutations or CSR mutations or vitamin D deficiency or decreased calcitriol formation. That can be nutritional rickets cause or renal failure or vitamin D resistance. Drugs causing hypocalcemia. What are the drugs which can cause hypocalcemia? Calcium chelators and biphosphonates, plicamycin. What is the mechanism in with biphosphonates? Decreased osteoclastic activity. The osteolytic activity will be decreased in biphosphonates and plicamycin. And vitamin D metabolism will be affected with phenytoin and ketoconazole. Vitamin D metabolism will be affected with phenytoin and ketoconazole. So biphosphonates and plicamycin and with calcium chelators. Calcium levels will be low. If there is hypocalcemia, there will be secondary hyperparathyroidism that causes elevation of PTH. What are other causes? Any other causes for high PTH with hypocalcemia? Pancreatitis, rhabdomyolysis and hungry bone syndrome. After parathyroidectomy, hungry bone syndrome can cause a severe hypocalcemia and secondary hyperparathyroidism. Or in prostatic cancer, in hypocalcemia, if PTH levels are high, these are the possibilities. Either there will be PTH resistance or with G protein, CSR mutations, okay, pseudo hypoparathyroidism, or Most important is vitamin D. Vitamin D deficiency or low calcitriol. That can be due to nutritional cause, rickets, or renal insufficiency, or with vitamin D resistance. In drugs, calcium chelators, biphosphonate placamycin group, and altered vitamin D metabolism with phenytoin and ketoconazole. Other miscellaneous causes are acute pancreatitis, rhabdomyolysis, hungry bone syndrome, and in a patient with hypocalcemia, if parathyroid hormones are low, then we should look for parathyroid gland causes, okay? Primary hypoparathyroidism. So either there can be parathyroid gland agenesis, isolated or discharge syndrome, or destruction, surgical radiation, or infiltration, or autoimmune. Even hypomagnesemia. What will it cause? Hypomagnesemia. How it will cause hypocalcemia? How hypomagnesemia will lead to hypocalcemia? Again, acting on CASR, it reduces PTH levels, and again there will be increased PTH resistance also. These are the causes of hypocalcemia. So if we check phosphate levels, what happens to phosphate levels with parathyroid gland agenesis or with destruction? Primary hypoparathyroidism. What happens to phosphate levels? What is the action of parathyroid hormone on kidney regarding calcium and phosphorus? Parathyroid hormone causes absorption, hypercalcemia, and phosphate excretion. So if there is destruction of parathyroid gland with low PTH, what will be the phosphate level? So there will be hypocalcemia and phosphate retention. In primary hypoparathyroidism, PTH levels will be low and there will be hypocalcemia with phosphate retention. So what happens to phosphate levels in vitamin D deficiency? So vitamin D means low calcitriol. Calcitriol deficiency, what happens to phosphorus levels? So decreased gut absorption of calcium and phosphorus. So there will be hypocalcemia and hypophosphatemia. Then what happens to PTH levels? If calcitriol is low, there will be secondary hyperparathyroidism. What happens to urine calcium level if there is vitamin D deficiency? So there is hypocalcemia. So urine calcium will be low. In most of the cases of hypocalcemia, urine calcium will be low, except in this CASR defect. CASR mutation. The mechanism is CASR in the tubule, it increases calcium excretion. That is the mechanism for hypocalcemia. So urine calcium will be high with CASR defect. Except in that condition, in most of the cases of hypocalcemia, urine calcium will be low. Then coming to hypercalcemia. Name some important causes of hypercalcemia. So hyperparathyroidism. Again, with CASR mutations, there can be increase in PTH levels. And Jansen's disease, there will be in Jansen's disease, PTH receptor activity will be high. PTH receptor activity will be, it almost behaves like high PTH action. But receptor activity is high. Just like in Liddle syndrome, JNAC channel activity is high. Similarly, in Jansen's disease, PTH receptor activity is high. If receptor activity is high, PTH levels will be low. In hyperparathyroidism, PTH will be high. Even with the CASR mutation causing high PTH levels are high. So hypercalcemia in CASR mutation, hyperparathyroidism, Jansen's disease, and hypophosphatemia. Hypophosphatemia, the alkaline phosphatase enzyme defect. There will be decreased mineralization of bone. There will be hypercalcemia and hyperphosphatemia. And granulomatous disease. In granulomatous diseases, there will be increased conversion of 25 hydroxy D to 125 hydroxy D. Increased calcitriol formation in granulomatous diseases like sarcoidosis, tuberculosis, even silicosis. There will be increased conversion to calcitriol. And vitamin D excess, increased vitamin D. If intake is more, there will be hypercalcemia. So what happens to phosphorus levels in these conditions? In hyperparathyroidism, what happens to phosphorus level? Hyperparathyroidism. So there will be hypercalcemia and low phosphorus level. Even CASR mutation, increasing PTH levels, phosphorus level will be low. Jansen's disease, action in the receptor. In the PTH receptor, there will be increased activity of the PTH receptor. There will be upregulation of PTH receptor. So again, phosphorus level will be low. In hypophosphatemia, there will be decreased mineralization of bone. So both calcium and phosphorus are accumulated in the blood. So phosphorus will be high in hypophosphatemia. In granulomatous disease, increased calcitriol formation. So there will be hypercalcemia and high phosphorus. Vitamin D excess, again phosphorus will be high. So coming to PTH levels. So in hyperparathyroidism, PTH will be high. In CASR mutation causing increased PTH will be high. But in this Janssen's disease, the mechanism is at the receptor level. So PTH will be low. In hypophosphatasia, there is hypercalcemia, PTH will be low. Granulomatous disease, increased calcitriol, hypercalcemia. So PTH will be low. The vitamin D excess, PTH will be low. So coming to 25 hydroxy D levels. So this cholecalciferol level will be high in vitamin D excess. Okay, cholecalciferol level will be high in vitamin D excess. What happens to calcitriol level? Calcitriol. So in hyperparathyroidism, what happens to calcitriol levels? Parathormone increases 125 dihydroxy vitamin D in kidney. So there will be increased calcitriol levels. So CASR mutation causing increase in PTH, same action, increased calcitriol level. Even Janssen's disease, there is receptor action, there almost a PTH action. So there will be increased calcitriol. So in vitamin D excess, increased calcitriol. In granulomatous disease, increased calcitriol. So only in hypophosphatasia, because hypophosphatasia, hypercalcemia and high phosphorus levels. Both calcium phosphorus levels are high. So there will be decreased calcitriol formation because there is no need for calcitriol to increase reabsorption from the gut. So calcitriol levels will be normal or low in hypophosphatasia. Coming to urine album, urine calcium. So if there is hypercalcemia, in most of the cases there will be increase in urine calcium except with CASR mutation, CASR defect. Because CASR action in the renal tubule, there will be decreased excretion of calcium. That is the mechanism for hypercalcemia. So urine calcium will be low with CASR defect. That is familial hypocalciuric hypercalcemia, FHH. Familial hypocalciuric hypercalcemia. The hypocalciuric because decreased excretion of calcium. So that is the mechanism for hypercalcemia. So in FHH, urine calcium will be low. In all other conditions, urine calcium will be high. So how do you approach this case? There is hypercalcemia. Check PTH levels. If PTH is high, normally it ranges from 20 to 70 picograms per ml. If it is more than 20 picograms per ml, if PTH is high, so there is hypercalcemia and increased PTH. Then check fractional excretion of calcium. If fractional excretion of calcium is more than 1, that indicates high PTH, hyperparathyroidism. Because in hyperparathyroidism, there will be hypercalcemia, increased urine calcium, and fractional excretion of calcium will be more than 1. So PTH is high, but fractional excretion of calcium is less than 1. What could be the cause? Familial hypocalciuric hypercalcemia. So CASR defect. FHH. See how simple it is. Check PTH level, check fractional excretion of calcium. We can diagnose FHH. Okay. If PTH is low, less than 20 picograms per ml. So what does it indicate? Hypercalcemia with low PTH. So mechanism will be in the gut. Then check 25 hydroxy D. Hypercalcemia, low PTH. If 25 hydroxy D is high, what does it indicate? Vitamin D excess. Excess vitamin D. If there is excess vitamin D, excess calcitriol formation, that causes hypercalcemia. Then that causes low PTH. If 25 OHD is normal, then check calcitriol. If calcitriol is low, what does it indicate? Or if calcitriol is high in this condition. So hypercalcemia, low PTH, high calcitriol. Granulomatous disease. In granulomatous diseases like sarcoidosis, tuberculosis, silicosis, there will be increased peripheral tissue conversion of 25 hydroxy D to 125 dihydroxy D. So there will be increased calcitriol in granulomatous diseases. If calcitriol is low, that indicates hypophosphatasia. Because in hypophosphatasia, high calcium, high phosphorus. So decrease in mineralization of bone because of the defect in alkaline phosphatase enzyme. High calcium, high phosphorus. Then PTH will be low and calcitriol will be low. So if there is hypercalcemia, high parathyroid levels, high PTH levels, and fractional excretion of sodium is less than 1. What does it indicate? FHH, familial hypocalciuric hypercalcemia. Fractional excretion of calcium will be less than 1. Hypercalcemia, low PTH, cholecalciferol is normal, calcitriol is high. What does it indicate? Granulomatous disease. PTH low, calcitriol is high, granulomatous disease. Hypercalcemia, high PTH, fractional excretion of calcium is more than 1. What does it indicate? Hyperparathyroidism. Hypercalcemia, low PTH, cholecalciferol is high. What does it indicate? Vitamin D excess. Hypercalcemia, low PTH, cholecalciferol is normal. Okay? but calcitriol is low, hypophosphatasia. Okay, so for various causes of hypercalcemia, increased parathyroid hormone secretion is primary hyperparathyroidism. So increased parathyroid hormone levels in primary hyperparathyroidism and in tertiary hyperparathyroidism. In CKD patients, in chronic kidney disease patients, there will be overstimulation of parathyroid hormone. So even with high calcium levels, PTH secretion will be high. PTH secretion is not regulated with hypercalcemia because of overstimulation of parathyroid gland in CKD patients. That is called tertiary hyperparathyroidism. Rarely even PTH, in some tumors can produce PTH hormone also, rarely. So mostly tumors, the solid tumors, they produce PTH related peptide. Rarely some tumors they can produce even PTH also. So any other causes of high parathyroid hormone levels causing hypercalcemia? Again, if there is CSR, calcium sense receptor, alteration will be present in lithium. Even lithium can cause the alteration of the CSR function. And second mechanism is hypercalcemia of malignancy. Hypercalcemia of malignancy. So there will be increased PTH-RP, PTH related peptide secretion by many solid tumors. Many solid tumors, they release PTH. It acts like PTH related peptide. Or there will be osteolytic metastasis, mainly myeloma, even breast carcinoma, myeloma. They are important examples for osteolytic metastasis. These are the conditions of hypercalcemia of malignancy. Or increased vitamin D, increased calcitriol formation, like in granulomatous diseases. We already discussed sarcoidosis, tuberculosis and silicosis, or lymphomas, or with vitamin D resistance. With vitamin D resistance, there will be increased vitamin D levels. So any other condition causing hypercalcemia? Increased osteolytic activity, even with thyrotoxicosis, immobilization, because it will increase bone resorption, releasing more calcium in thyrotoxicosis and immobilization, or increased calcium intake with milk alkali syndrome or total parental nutrition. So increased calcium intake with milk alkali syndrome or with total parental nutrition. So increased osteolytic activity with thyrotoxicosis and with prolonged immobilization. There will be increased bone resorption. Also high vitamin D, high calcitriol levels with granulomatous diseases and with lymphomas. And hypercalcemia malignancy, mainly solid tumors, breast carcinoma and myeloma. And high parathyroid hormones in primary hyperparathyroidism or tertiary hyperparathyroidism, or with altered CSR function and with lithium also. There are some endocrine causes which can cause hypercalcemia. Adrenal insufficiency can cause hypercalcemia. In pheochromocytoma or lipoma, there are many endocrine tumors, they can cause hypercalcemia. Do you know the mechanisms in adrenal insufficiency? There are various mechanisms. One is hypovolemia causes decreased calcium excretion. So adrenal insufficiency causes hypovolemia, hypotension. So decreased calcium excretion is one mechanism for hypercalcemia. If there is complete adrenal gland involvement, glucocorticoid levels will be low. What is the action of glucocorticoid on calcium metabolism? Steroids on calcium metabolism. Mainly the reactions. So steroids, they increase calcium levels or decrease calcium levels. We will give steroids in hypercalcemia or hypocalcemia. We will give steroids in hypercalcemia. One mechanism is steroid glucocorticoid, they decrease calcitriol formation. That peripheral conversion will be reduced with glucocorticoids. That is one mechanism. And even in the kidneys also there will be increased excretion of calcium. So glucocorticoids, they inhibit calcitriol formation. If glucocorticoid is low, in adrenal insufficiency, if there is complete adrenal gland involvement, glucocorticoid levels can be low. So that leads to hypercalcemia. In pheochromocytoma, what are the mechanisms? Pheochromocytoma can be part of multiple endocrine neoplasia. So with parathyroid gland involvement or with thyroid gland involvement, high calcitonin levels. Calcitonin is produced in thyroid gland. So as a part of multiple endocrine neoplasia, calcium levels can be high. In lipoma, it acts like, it releases peptides. They cause hypercalcemia and they act like PTH hormone. There will be increased bone resorption. Drugs causing hypercalcemia, thiazides, by causing hypovolemia, they decrease calcium excretion. Or vitamin A can cause hypercalcemia. There will be increased resorption of bone with vitamin A. Anti-estrogens. We use tamoxifen in breast carcinoma. When that can cause hypercalcemia. These are the various causes of hypercalcemia. Okay.